So good morning, everyone, and welcome to our rainy morning March Grand Rounds. I'd like to start by acknowledging that the lands on which we are hosting this meeting include the traditional territories of many nations. No matter where you are attending, I invite all attendees to reflect on how we may commit ourselves to gaining knowledge, forging new culturally safe relationships, and contributing to reconciliation. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. I'm very excited this morning to invite Dr. Michael Mindrum to present and thank him for presenting. He's an assistant professor with Dalhousie and practices general internal medicine in Kentville, Nova Scotia. He's a diplomat of the American Board of Obesity Medicine. He's interested in patient education, behavior change, and technology in healthcare. His career goal is to help develop a provincial framework for obesity in Nova Scotia. He grew up in the United States, but completed his medical school in Louisville, a preliminary year of medicine in the University of Hawaii, super cool, and his internal medicine residency in the University of Vermont. Along the way, he married a Newfoundlander. And after several years of working in Vermont, him and his wife, Dr. Christina Mindrum, moved to Nova Scotia. After another year of training at Dalhousie, he established his practice near Kentville. He's a proud dad to 3 beautiful kids between the ages of 10 to 12. He's pleased to be here this morning to discuss the topic of obesity pharmacology. As per usual, there'll be a survey at the end to complete. If you pick the survey up from our links today, it will work. And if you pick it up from the invitation that was sent yesterday, it will work. But if you go to any emails older than that, the survey was not correct. So please, again, go to your invitation from yesterday or pick it up here from the chat. We will do 45 minutes or so for Dr. Mindrum to talk, and then there'll be time afterwards for questions. If you have questions and you're afraid you're going to forget them, please feel free to put them in the chat as we're going along. And so with that, I will thank Dr. Mindrum again and pass it over.
Thank you so much, Dr. Bussey. Everybody hear me okay? Good. And for that introduction, one small correction, it's Dr. Krista Mindrum as opposed to Christina. It happens, but I'll just in case you meet her in the future. So today we'll talk about obesity pharmacotherapy in primary care, a prescription for healthy weight. And here's my disclosures. We give some talks and do some consulting work with pharma, and also been a principal investigator in some obesity trials, no drugs that I'll be speaking about today. And objectives, pretty simple. Learn a little bit more about obesity. Now, Dr. Vallis already gave a talk last year, so I'm not going to delve into a lot of the pathophysiology and so forth today. Learn about obesity drugs, feel more comfortable with an approach to prescribing, and have an appreciation for what's to come. So I'll start with the definition of obesity, just as a reminder. Obesity is a complex chronic disease involving abnormal or excess body fat that impairs health, increases the risk of long-term medical complications, and reduces lifespan. So this is from Obesity Canada. And one glaring absence here is the term BMI. So body mass index isn't anymore located in our formal definition in Canada. Now we still use BMI as a way to categorize and stage or categorize obesity or communicate about it. But this is really to say that a person could live with an elevated body mass and not have the disease of obesity, or could even have a lower body mass and have the disease of obesity if their body fat is abnormal or not functioning properly. So this is the deep dive into the pathophysiology of obesity. This is going to be about it for you all today. One is can classify it as fat mass disease. And so that's excess fat that's causing mechanical pressures. So this is kind of the sleep apnea, the gastroesophageal reflux, the pressure on joints, these sorts of things. And then the other is sick fat disease, and that's really dysfunctional fat in the subcutaneous tissue, the white adipose tissue. And so that's really a limitation in the individual's capacity to expand their fat, and rather than the fat cells replicating and staying small, they get large, insulin resistant, and then you get fat overflow into the viscera and ectopic fat in things like the liver and the pancreas. And this leads to things like type 2 diabetes, hypertension, heart disease, and so forth. So these two processes really manifest in over 200 different kind of appearances of obesity and are predominantly what we often see in chronic disease management, but not always recognize that it's actually obesity that's revealing itself. This is the brain, and we do know that obesity resides in terms of its location in the predominantly in the subcortical brain, or the non-conscious brain, where body weight is regulated. The homeostatic system there is related to the hypothalamus, and specifically a group of neurons in the arcuate nucleus. And this is kind of more or less where the set point or thermostat for body weight is regulated, sensing what is happening in the body. And then if energy status is low, knocking next door on the mesolimbic system or our limbic system, which is our motivational drive to seek energy from our environment, to restore that energy. And then we also have executive function, and that has to do with our ability to discriminate, choose, and so forth. And quite often when we're talking about behavior change, we're talking about the executive system and our ability to discriminate and choose, but predominantly the biology of weight regulation is in the non-conscious brain. And if I could point you towards Dr. David Macklin's video to watch sometime, you can just Google gatekeeper, go-getter, lazy executive. He has a nice kind of cartoon about what these areas of the brain are doing. The gatekeepers in the homeostatic system, the go-getter is in the mesolimbic system, and the lazy executive is up in the executive system. And I just want to highlight, say something that might look in my chart. And this is to kind of bring in what an assessment could look like. And in the top right corner there is the Edmonton Obesity Staging System. And I think we could, with time, get more scientific about what we mean by stage 0, 1, 2, 3, and 4. But an example would be stage 0 might be dyslipidemia. Stage 1 would be prediabetes. Stage 2 for kind of the medical part would be type 2 diabetes. Stage 3 would be type 2 diabetes with end organ complications, heart attack, nephropathy, and so forth. And then stage 4, we're getting into severe end stage disease. And ideally, we start treatment earlier than later. And so this individual in the biometrics here, current weight 204 pounds, BMI of 39. And I also like to keep in my chart what their max weight was compared to their current. So if somebody is living with an elevated weight, but they've lost 20% of their body weight when we're meeting them, that really can tell you a lot already. And also delta start is, for me, is when we first started managing obesity and where we are now. And that also kind of gives me a reference point to the trajectory that things are going. So this is Sonia, a 54-year-old female with class 2, stage 2 obesity. And the class 2 has a BMI of 35 to 40. Stage 2 because of type 2 diabetes and gastroesophageal reflux or sleep apnea and so forth. So the 4 M's is also coming from Obesity Canada. And this is thinking about obesity through this kind of lens or prism spectrum, thinking about metabolic complications of type 2, metabolic complications of obesity. They have type 2 diabetes, hypertension, dyslipidemia, metabolic associated fatty liver. Mechanical complications, based on the history picked out, mild sleep apnea and heartburn. Mental distress, and this can come in different forms of distress, but this individual had a history of emotional trauma, and it's not necessarily the cause of obesity, but it's something to be aware of. There can be interplay there. Moderate internalized weight bias, that's a real subjective call there. I don't have a survey yet. I think we'll be developing those. And somebody with a history of depression that's currently stable. Then social milieu, this is kind of thinking about work, relationships, education, financial distress. and considering how obesity could be impacting them on that front. And then in terms of a plan, we will be talking about obesity medications, but there's a context to these medications in terms of a treatment plan, just considering some kind of holistic approach. And these are just the elements I've decided to put in my own plans and recommendations to help me stay organized. And so I kind of touch upon things like behavior change, nutrition, movement, sleep, mental health, obesity medication, bariatric surgery, blood pressure if they have type 2, think about their lipids, and so forth. So this is just those headings are things that I just keep in my recommendations for obesity. You don't have to address them all at the same time, of course. And I think like here for nutrition, this could be referral. This is a group that I refer out to for nutrition quite often called Constant Health. Movement include a bit of like how ready they are and what the plan is, but also just touch base on things maybe that we didn't talk about. So sleep, didn't talk about today, didn't have time, but I noticed that their stop bang survey was positive. And medications, often it might be they need to first check out to see if they have any coverage, and I know that they don't have the financial means to pay for it. So not worth going into all the details of drugs if we're not going to be able to use them. So this time this patient's going to, well, they actually had a prior auth form for semaglutide and a prescription was sent. Okay, fair enough. So as we go forward, there's this concept of treating to target, and this is derived from either RCTs, observational data, bariatric surgery, lifestyle, and different degrees of weight loss address different chronic diseases to different extents. So as you go up to higher degrees of weight loss, say 15% or more, then we can get into the realm of type 2 diabetes remission, reduction in mortality. A little bit less weight loss, we're really treating heart disease, metabolic associated steatohepatitis, osteoarthritis. And so with behavior change and lifestyle, we can often expect a 0 to 5% long-term reduction in body weight. And you can see here, we're kind of catching the tail end of a whole bunch of chronic diseases. These are still important to address. And then as you get into higher weight adjustments with behavior change and medical therapy, we're getting more into the meat of the matter here in terms of resolving underlying disease states or improving them substantially. So it is possible that if we treat in this fashion, we could be peeling off other medications or preventing further risk. And then at higher weight reduction, we're getting into the diabetes remission, treating heart failure with preserved ejection fraction, and so forth. And here's a called the DIRECT trial out of the UK. This was in 2018. And they put individuals on a 6-month low energy diet and see what happened at 1 year. And they had diabetes for less than 6 years, nobody on insulin here. And what they see is a real correlation between weight reduction and type 2 diabetes remission. So as you get into 10 to 15% weight loss, there's a 60% remission of type 2 diabetes. And at 15% weight loss, a 70% remission. And current therapies on the market give us more of this 0 to 10 or 5 to 10% weight loss. Now we can't define diabetes remission when somebody's on a drug, because you really need to be drug-free for the definition of diabetes remission. But it gives you a little benchmark to say, okay, how are we doing in terms of addressing the underlying pathophysiology? Really what's happening here with weight reduction is that you reduce the fat in the pancreas and the liver, improve insulin sensitivity. You reduce the fat in the subcutaneous tissue where you can safely store energy. So all of a sudden now you have increased kind of capacity or safety to store energy in the subcutaneous tissue. And in this case, they also checked to see if beta cell function could get better. And in fact, it did. It didn't go completely normal, but these beta cells, there was still function there that came back online with the weight reduction. So the beta cells had, in fact, not completely died. So why not just eat less? And this is a mental exercise. It's 500 calories per day. Deficit is often what we recommend. That's 3,500 calories per week, which is a pound. That's 52 pounds in 1 year. So if you start at 250 pounds and follow that trajectory, by 5 years, you're absolutely gone. You've disappeared. So not an atom left. And that we know doesn't happen. And, intuitively, you could say that there's something evolutionary or biologically powerful that wants to preserve our mass, probably to pass on our genetics. And this is where we know that in the subcortical brain and the non-conscious brain, where there's a lot of automatic function, there is, in fact, a defense against weight loss. Short-term weight loss is certainly very feasible. 40% can lose greater than 5% of their weight at 1 year. 20% can lose greater than 10% of body weight. And, this can feel really good. And the issue is we know that weight regain long-term, even with good support, is extremely common. So within 2 years, half of the weight loss is regained. At 5 years, 80% of the weight is regained. And this isn't an issue with decreased willpower and things like this. This is known to be really biologically driven. The landmark study here, 2011, just showed how with weight regain, there are powerful biologic adaptations. So the hormones that lead to hunger go up. That's like ghrelin. The hormones that lead to satiety, such as PPY, amylin, CCK, go down. So these last for a very long time. And Kevin Hall worked out some math here. He studies obesity, but his background's in physics. And this is above my head in terms of understanding this paper, but we'll have to go based on faith here that this is real. It makes sense too. So every kilogram weight loss, you get about 100 kilocalorie per day increase in wanting and appetite, and about a 25 kilocalorie per day decrease in metabolic rate. So there's that the gatekeeper is sensing low energy and tapping next door on the go-getter to go seek calories in the environment. And that's what's happening here. And the direct trial really caused a real reverberation through, say, the diabetes community. And many read it as a watershed moment in terms of diabetes remission through lifestyle, while the obesity community rumbled, knowing that we shouldn't follow things at 1 or even 2 years, but need to think about 5 years out. And this data was just published recently that in the look ahead trial, weight regain, in fact, did happen. Now, it didn't go up to the 80% weight regain. So this just shows how intense the intervention is. They put people back on meal replacements if they're regaining weight and so forth. But weight regain's happening, and there's a real degradation of type 2 diabetes remission over time. And depending on the math here, it's anywhere from 7 to 11%, depending on how it was measured. So still a real minority of people maintain diabetes remission long term with lifestyle alone. This is another role for considering pharmacotherapy or other interventions and not only leaning on lifestyle. That's, of course, the patient preference, and we can follow people along, but just thinking that there's other tools in the toolkit to consider here. So the weight plateau, we really consider as reframing it as something called best weight. As we lose weight, the subcortical brain defends against weight loss, and whatever led to the weight reduction needs to be continued for the weight maintenance. So it's the same effort needed for weight maintenance as it is for weight reduction. And often patients lose, say, 3 to 5% of their body weight with lifestyle change, and their expectations may be more like 30%. and it feels like a real failure to them. And if we as clinicians continue to say, just buckle down, work harder, we know that their subcortical appetite system's going to go up, their metabolic rate's going to go down. And if they do white knuckle willpower at lower, we congratulate them. We may be missing a real important aspect of the joy of their life. How are they doing? And once that willpower, it's an exhaustible resource, then that biologic adaptation comes back and weight regain happens. Fat mass tends to regain quicker than any kind of lean body weight that was lost. So this is getting into this kind of yo-yo experience that many have gone through before they even meet with us. Best weight and say metabolic health or improvement in diabetes, fatty liver, sleep apnea, etc. There's often a therapeutic gap there. And the question is how to close that, and whether to treat symptoms of the diseases or treat obesity. So 3 pillars of obesity management. This is from Obesity Canada. I adapted the infographic here. So at the base of this Greek structure is the clinician-patient relationship. So this is really this dialogue and relationship between you and your patient. And it's really key there. A lot of it has to do with education, developing a bond, coming up with shared tasks and goals. So if a patient's goal is to lose 30% of the body weight, it's really important to have that conversation, think about realistic expectations, what really is their goal, how they want to feel and function, and really eventually kind of dropping the weight goal and looking more and more at function and health. And now patients still may be stuck on the number on the scale, but as physicians, unless you're in aesthetics or cosmetics, we're really thinking more about body weight and health from that perspective. Although still, I think it's reasonable to think about their mental health, their self-image, and things along those lines. So then there's these 3 pillars, and the 3 pillars can be all psychology and behavior change, nutrition, lifestyle. You can also add pharmacotherapy, or you could add pillar of bariatric surgery. And what these pillars do is they support movement and nutrition and healthy lifestyle. So they're not a substitute, but they're a way of supporting. So it relieves the subcortical brain's drive for increased energy intake. And once you do that, if you treat it really effectively, lifestyle interventions become much easier, or much more natural. There isn't a constant willpower needed in terms of that kind of white knuckle willpower. So the idea is to lower these barriers to allow a person to enter into an energy deficit and maintain a lower weight long-term for health and well-being. So a lot of education there is needed, and you're free to use this resource I created. It's on Valley Metabolic Health, which is the website that I have for my clinic, and find Empowering Health, Your Best Weight Journey. There's about 25 short videos there that take people through different concepts of obesity as a chronic disease, role of medications. And I often have patients watch this before I meet with them, and I find it kind of allows people to come in much more informed and have good pointed questions and have considered things for the first time. Now, I used to, when I used to do this before this, I would have that conversation with them, and honestly, it would be a really enjoyable day in a way because of really addressing weight bias and stigma that many had not ever thought about it or heard about it, or the issue of thinking about obesity as a chronic disease. So this is a real, that can be a powerful conversation, but it does take time. And this is something I found helpful. Switching over to obesity pharmacotherapy, we have kind of in our background some issues in society and medicine around bias and stigma and how We've really caused a lot of people harm. And also, we have a lot of missteps in the history of pharmacotherapies for obesity that have caused harm. That's all the way up till recent past of 2020. So we've caused cataracts, neuropathy, death, addiction, valve disease, pulmonary hypertension, depression, suicidality, cardiovascular toxicity, increased cancer risk. And some of these weren't all used for, I think they were on the heels of weight bias and stigma, as opposed to thinking about health, especially the amphetamine and rainbow pills that were being given out of doctors' offices. So kind of a truth and reconciliation about our past with obesity is important as well. So with that, Health Canada and the FDA approve obesity medications in individuals with a BMI over 30 or a BMI of 27 plus one weight-related condition. Studies also have to be more than 1 year in duration and have greater than 5% weight loss in over 35% of patients. And in retrospect, this was an extremely low bar. We have 4 drugs on the market now: orlistat, liraglutide, naltrexone, bupropion, and semaglutide, which is Health Canada approved, and it should be coming out, the last one there, sometime in the spring. The 4 C's is what kind of think about in terms of which drug to consider. Think about the contraindications, the cost and coverage is really key, comorbidities, and choice. And this is coming from Adapted Obesity Canada guideline algorithm. And first step there is the BMI over 30 or 27 plus comorbidity. And first step is thinking about it, are they on any weight promoting drugs that we could substitute? And there's a nice chart that you can find on the guidelines about antidepressants, antihypertensives, a lot of drugs that can lead to a 3 to 5 or 6 or more, especially antipsychotics, very weight promoting. Are there other drugs we could substitute? Then if they have comorbidities like hypertension, PCOS, or sleep apnea, you move over to the, if possible, level 1 grade A evidence for semaglutide 2.4, which again will come out sometime in the spring, we hope. And if they have type 2 diabetes, we have level 1 grade A evidence for liraglutide 1.8 and semaglutide 1. And then still staying on the left-hand column, level 2 grade B evidence for liraglutide 3 milligrams and orlistat. And then if somebody has cravings and smoking, there might be a consideration of Wellbutrin because of that smoking cessation aspect, naltrexone. We could also consider liraglutide, orlistat, and semaglutide, which will still have that level 1. So I'll run through some of the drugs on the market now. A little review of history too. Orlistat, Health Canada approved 1999. Its mechanism of action is inhibit pancreatic lipase. Its effect is to reduce fatty acid absorption, and its side effect is oily stool, flatulence, and incontinence of stool. So it might be the reason why adherence rates are so low. But this was like what we had in 1999. And it led to, at 3 years, a 2.7 kilogram weight loss. The relative risk reduction of progressing from prediabetes to type 2 diabetes was there. A1C reduction in type 2 wasn't too bad at 0.4%. But again, a lot of the side effects is the issue. And so placebo, 1999, we have this 4% weight reduction. And how sad that's all that we had in Canada. Then in 2014, there's a real winter or dry spell where not much was happening. A lot of us were going through education during this time. And so bupropion naltrexone, it really affects the homeostatic and mesolimbic system. It reduces subcortical wanting and side effect of nausea, constipation, diarrhea, and headache. Now we're getting into a placebo-subtracted weight loss of 6.35%, pretty moderate effect, and some reduction in type 2 diabetes. And bupropion naltrexone really hits both the hypothalamic system as well as the mesolimbic, and that's where it's a mechanism of action. In the hypothalamus, when there's a POMC stimulus, this is a signal that leads to fullness. It goes into the lateral hypothalamus with the where the MCR4 is. And then there's a feedback mechanism of opiates back to POMC. And so that's where the naltrexone affects. So bupropion kind of pushes things forward to MC4R to reduce appetite. And then the naltrexone inhibits the feedback mechanism to amplify. So there's a synergy between bupropion and naltrexone. And here you get some of the side effects of nausea, constipation, headache, 10% vomiting, and then the lighter color is placebo. And here's the dose titration from 1 tablet daily for 1 week, then 1 tab twice a day, 2 tabs daily, and 1 tab at night, and then 2 tabs twice a day. You do need to think about a lot of drug interactions and contraindications, so not to be used if they had uncontrolled hypertension because of naltrexone. This should be off codeine or opiates. Any history or risk of seizures, MAOIs, hepatic impairment, pregnancy, and stage renal disease, and also caution with low-carb diets because of increased absorption. I always pull up a drug interaction kind of device anytime prescribing bupropion, naltrexone, and just some high-level things. Start low with any addition of an SSRI, caution with beta blockers, antipsychotics, and TCAs, and don't use with levodopa. And it's metabolized by CYP2B6. So max dose is 1 tablet twice a day of this therapy if they're on taclopidine or clopidogrel. And then also avoid if they're on some of these anti-epileptic drugs, Tegretol, phenobarb, and phenytoin. And so now we've up to 2014, we have a little bit more effect and a bit more tolerated drug. And next on the list is liraglutide at 3 milligrams. So this is a neuropeptide produced by the gut, acting upon the homeostatic center in the brain. Its effect is to reduce the homeostatic set point, and it also commonly causes nausea, constipation, diarrhea. And so it's a modification of the human endogenous GLP-1, and it thus escapes DPP-4 degradation. So it's a member of this incretin family. And the GLP-1s have really been the cornerstone of current and future pharmacotherapies. So GLP-1s made in the L cells of the gut, and then GLP-1 receptors are also expressed in multiple different organs. So as you look at the effects of GLP-1 on health outcomes, there's sometimes also some thoughts about weight-independent effects of GLP-1 receptors. So GLP-1 stimulates POMC, and I think about that as pom-pom, like cheerleaders saying, hey, we're full. And then on the other side, it inhibits MPY-AGRP. And POMC and MPY-AGRP are kind of like the yin and yang of our homeostatic system. And this is kind of altered towards hunger, increased hunger and less satiety over time in the situation of obesity. And so this is just changing the tone of these two groups of neurons to reduce the set point over time. Now we're at an 8% weight loss rather than 36% type 2 diabetes risk reduction. We're at 80% at 3 years, and 1.3% A1C reduction in type 2 diabetes, and reduction in sleep apnea events. So we're now moving into demonstrating more meaningful impacts on end organs and so forth. Not to be used if they had pancreatitis. Now, I do have some caveats there myself. I think about what was the cause of pancreatitis. If it was something really clear and it was mild, then I'm more keen on utilizing it. And then also if they've had a personal or family history of medullary thyroid cancer, MEN2 syndrome, and that has to do with rats developing medullary thyroid cancer. It hasn't been observed in humans, and not to be used in pregnancy. These are the common side effects. Liraglutide, there was a signal towards pancreatitis that hasn't been seen in any bigger studies with semaglutide or meta-analysis and so forth. I'm going to add here now the side effect of liraglutide, which is in the orange, compared to bupropion naltrexone, just for reference. And you can see now there's a little bit more nausea, definitely more diarrhea, about the same amount of constipation, slight increase in headache compared to placebo, and more vomiting. And these episodes are usually transient and short term, especially around dose escalations. And so the vomiting isn't something people experience all the time. It's usually, of course, just an occasional thing, although I hate vomiting, so I wouldn't want to experience it even once, but people do get through it, and it happens 10-15% of the time. It doesn't really have any drug interactions, although theoretically could affect absorption. And here's the prescription of 0.6 sub-Q daily for a week, then 1.2, 1.8, 2.4, and then 3. And so side effects are often mild. You can maintain the current, I personalize this, and I think pharmacists that get on board would be really helpful here. If side effects are there, maintain the current dose. Return to prior dose if side effects are too much. And if somebody's appetite's really knocked down, no need to increase the dose. So having a patient listen to their hunger cues and satiety, and it's okay to take it really slow. And I think with that, people can tolerate the drug. And for some people, it takes months, if not a year, to get up to the target dose. And I'm going to skip over, well, I'll just say that this was a low energy diet that was done in the scale trial weight maintenance with liraglutide. And they lost 13% of their body weight by week 8. And then they were randomized to placebo, green as exercise, liraglutide alone, or liraglutide plus exercise. And just to highlight the importance of exercise, especially at weight maintenance, and this tends to run through elsewhere. And also what happens when you stop, when you don't add drug therapy and the biologic adaptations that happen here. So now we're at about a 6% weight loss in 2015. Next on the list, semaglutide 2.4, and this is, again, hopefully coming soon. It was Health Canada approved in 2021. We've been waiting. So the mechanism of action is just like liraglutide, no different. And what they did, it was add this fatty acid to the GLP-1 that allows longer half-life, and that's the same as the semaglutide 1, and allows you to do weekly dosing. And this is what it'll look a little bit different than the semaglutide 1. And unfortunately, it won't be a multi-click pen, but it'll be fixed doses, which I think is going to be a problem, or we could have avoided problems if it was multi-click. But each pen, you'll go up over 4 weeks to the target dose of 2.4. And a lot of these trials now have these different stages. Step 1 in this trial was looking at obesity, then type 2, its effect with intensive behavior therapy. What happens when you treat and then stop? Does it allow for weight maintenance or not? This is a 2-year study, and this was comparing it to liraglutide 3. Just to highlight, 1 was the step 4, or the weight, the maintenance trial. And this is the weight loss that happens in the green with the drug, and then they stopped it to see what happens. And those that continue to lose weight. At 1 year, weight regain had recurred, along with blood pressure, A1C rise, triglycerides going up, and so forth. So the idea ideally is to continue therapy. And here's kind of the categorical weight loss across all these step trials. The 5% bar for approval, we're now into the high 65% or more for people achieving that. And then you can see that there's still a large amount of people achieving weight loss of 10% or more, around 45% for 15%, and 25% will lose 20% of their body weight with this drug. You also have decreased weight loss, a drop on their blood pressure, so very effective antihypertensive, and inflammatory markers also markedly go down. And this comes with slightly increase in the light blue side effects of nausea, diarrhea, constipation, and vomiting. And again, I think this could be modified with more careful dose adjustments. So we saw these improvements in cardiovascular risk factors, and the SELECT trial was therefore done that looked at patients with obesity, no type 2 diabetes, and coronary artery disease, see if it lowered cardiac events. 17,000 people were involved in this. It was a 10% weight reduction, a drop in systolic blood pressure, CRP, and change in triglycerides. So an 18% drop in triglycerides, which is always a good sign. And there was a reduction in major adverse cardiac events with a separation in the curve quite early. And one of the sub headings for this was all-cause mortality, where the most evidence was seen. So the relative risk reduction was 20% in that trial, an absolute risk reduction of 1.5, a number needed to treat at that timeline of 66. So if you extend the trial, most likely that NNT goes down. This is on top of really intensive statin therapy, blood pressure control, and all the other things. So an important study there. And that's what we'll see as ongoing end organ studies. We already have a publication of heart failure and preserved EF with Ozempic semaglutide 2.4 without diabetes that showed increased function. In type 2 diabetes and CKD, you'll find that hasn't been published yet. There'll be reduction in kidney events. So we'll look forward to that one. And now you can see an acceleration in the amount of weight loss and likely its efficacy on organs. And so in the pipeline, we have GLP-1 is the backbone of all these therapies. And then where pharmacotherapies are now being added a GIP, you can add amylin, GIP plus glucagon, PYY, and then there's triple therapies, GLP-1, GIP, glucagon, for instance. So we're about to get an onslaught of new drugs that have meaningful impact. And here with tirzepatide, which is now Health Canada approved for type 2, not for obesity yet, it has FDA clearance in the States. So at greater than 1 year for type 2, which is really hard to achieve greater than 10% weight loss, they had an average of 15.7%, and obesity 22.8%. And just to reference, a vertical sleeve gastrectomy is about 25% to 30%. So we're really moving the needle here on the amount of weight that can be achieved, weight loss achieved with drug therapy, and a minus 1.6% A1C in type 2 diabetes. So tirzepatide is now here in Canada, but only in vials right now. The pens aren't here. And I haven't been able to prescribe it. I might prescribe it once, but a patient has to be comfortable with the vial, putting in a needle. There's only a 5 milligram vial. So the first dose is 2.5, so they have to waste it for that first month. And the therapy kind of goes 2.5 for a month, then 5, then 10, and then 15. And you can see the A1C just drop like a rock to this level. So I'm jealous of new grads and doctors that didn't have to suffer through the 90s and 2000s with insulin, metformin, and sulfonylurea, and that's about it. And then we get excited about glitazones, and then that caused heart failure and maybe heart attacks. And people are just going to think about diabetes completely differently in the future. And I'm happy. This is what I see as I'm happy for patients and for the providers. So this is a really joyful thing to see. Tirzepatide is a GIP and GLP receptor agonist. It's a single molecule. These are the receptors that are kind of sitting in the membrane, GLP-1 receptor and GIP on the right. And tirzepatide kind of nicely fits in these little receptors to affect them. And tirzepatide is a more potent GIP receptor agonist than GLP, which probably has a little bit to do with its side effect profile and efficacy. So now I'm going to add tirzepatide to the type 2 diabetes categorical weight loss, and you can see a real acceleration in how much weight reduction is happening. And tirzepatide's on the horizon, and you can see the weight loss that's better than semaglutide 2.4 by a significant margin. And then I'm going to add now, so this is kind of just all the drugs together, the categorical weight loss. And you can see over time, we're getting into higher likelihoods of achieving 5% weight loss, 10%, and 15% or more. And semaglutide or tirzepatide's in the green here. And despite the increase in efficacy of the drug, there's no real increase in side effect profile. So it's very well tolerated. And just to say, here's the future. This is only a select number of drugs. So we've gone up to semaglutide 2.4, the darker blue in the middle here. And now the lighter blue, oh, sorry, this is semaglutide 2.4. Or no, sorry, semaglutide 50 orally is this lighter blue. I don't know if you see my arrow. This is the Oasis trial. And so this is like the semaglutide 14. You can see an oral therapy that's more effective than semaglutide 2.4. And then as you move over, CagriSema in the orange, survodutide in the mustard yellow, and then retatrutide is a triple agonist that's really approaching bariatric surgery weight loss. So these are kind of entering phase 3 trials now. So I'll finish with obesity is both a medical disease and just say it's also a social construct. So we need to care for the disease if and when it exists, but also care for the harm of obesity bias and stigma. I didn't talk much about that, but I think that's equally important. We're in a new era of pharmacotherapies that will provide near bariatric surgery level of weight loss. It won't be a substitute for bariatric surgery. And these therapies can be added on to bariatric surgery as well. And there'll be growing evidence base for particular anti-obesity drugs to prevent end organ damage. So we may have particular anti-obesity drugs that are, because of their pharmacokinetics or their pharmacology, better, say, for metabolic fatty liver disease. And so there'll be that algorithm for Obesity Canada is going to become growingly complicated. Bariatric surgery is still going to be needed. It's among the most cost-effective interventions in medicine. And the ongoing increase in prevalence of obesity, I think that will decline over time, along with expansion of drug therapies will lead to more complex decision-making. There'll be a need for specialty care and kind of an expansion of specialty care in obesity. But similar to type 2 diabetes, care is going to be increasingly in the primary care office. So similar to how type 2 diabetes. And so becoming more and more familiar with these therapies, getting comfortable treating it, just like kind of treating hypertension, the drugs can be learned in terms of their side effects. And kind of thinking back to my assessment about thinking about using the Edmonton obesity staging system, the class, what percentage of weight loss. And I'll also say, because of how powerful these are, we need to kind of individualize treatment. Not everybody needs tirzepatide 15 milligrams and a 23% weight loss. In fact, that could cause harm. So we want to think about treating the disease process, protecting against excess weight loss, thinking about these older patients that already have some decreased muscle mass. I'm concerned about inducing frailty, or those that have the strong social pressure to lose weight. We need to be careful not to overtreat individuals because of that. So that's it for today. You can find me on Twitter, where I'm pretty active, take breaks, but pretty active. There's there's a website. There's professional and patient resources there. Feel free to email me. We've created a Nova Scotia Obesity Network kind of email network, and hoping that kind of keeps us connected and help develop a framework for obesity care. And I'd also ask you to kindly advocate wherever you can for increased access to bariatric surgery, which we're about a decade behind, and we need to increase probably 10 to 100-fold in number of surgeries that we do to adequately treat a really important and vulnerable patient population. So that's all for today. Thank you for your attention. 8 o'clock in the morning. You now have a long day of work ahead of you.
Thank you so much, Dr. Mindrum. That was a really amazing overview. It's incredible just to see what's. I'm not super watching this set of literature, and so it's really amazing to see what's coming. There's a couple questions in the chat, so I'm going to go there. The first thing I'm going to ask, though, because I think probably other people are wondering, with your are you only serving people in the Valley with your clinic, or are you accepting referrals Nova Scotia wide?
Yeah, I see people from everywhere. Not much Cape Breton. Haven't seen anybody from Cape Breton. And they do have a clinic in Cape Breton that I hope is serving better their population. But I do see people from the Central Zone, South Shore, Valley.
And is there any private pay element to it, or is it publicly funded?
No, it's all publicly funded. Yeah. My wait list is now a year or more, so that's kind of a disappointment, but it's just the way it is, and I think it'll keep growing. So we're hoping to, like, the Cape Breton has a obesity hub. We're putting in a business proposal for an obesity hub in the Western Zone, but that will still take about a year and a half from now. So if you have political connections there, please tell your folks that we need a obesity hub in various zones. Central Zone is also really underfunded for a bariatric clinic that's supposed to serve the province. They need probably 10 times the size that they are. And it's really important that we not only prevent obesity and focus on that, but we treat the people that are suffering from the disease. So yeah, I think that needs an incredible increase in funding and access.
Right. Well, hopefully there's some people on the line who can help. I'll go to the chat. The first question I typed in myself, if a patient can't access semaglutide for a month or so, there's been drug shortages, can you go back onto their last known dose, or do you have to start the titration all over again?
If they've missed 2 days, just keep going. If you're getting to 2 weeks, I would drop the dose. And past 3 weeks, I think I would start all over again at the lowest dose.
Okay, thank you. The next question, how long do you keep people? Yeah, what's the exit plan for semaglutide?
Well, you see the exit plan is they lose coverage, they can't afford it, some kind of intolerance, and then you have to think about alternative strategies, and sometimes people stop the therapy. There's a weight regain that almost universally happens in the trials. I have met people that maintain a lower weight, and if they are going to stop therapy, lifestyle interventions, higher protein, more intense exercise, resistance training would be really key to see what happens. And maybe with time, we'll find out that there is some intermittent dosing that can happen during maintenance. So that's just not in the studies yet, but there is some talk about, given the cost, expense, we need to probably experiment with how to treat at maintenance. Is there some role of cyclic therapy and things like that? But there is the exit strategy would be long-term therapy if at all possible.
I think the second question is maybe similar. So regarding duration of pharmacotherapy and weight regain, in your clinical experience, have patient ever been able to stop medication and maintain adequate weight goals? I think you kind
They
of
have, I've had it, on average, people regain weight. And I share with them that they're going to experience increased wanting, increased noise. Important to say, don't blame this on yourself. It's really biology. You're doing nothing wrong. And then focus a little bit more on, are they able to do resistance training, nutrition therapy, and the behavior change as well, like kind of dusting that off and getting back into goals, values, meal planning, restraint around wanting. But it's a challenge. It's really biologically moving in terms of weight regain. But I've had some people that maintain a lower weight. I've also had people regain weight, restart therapy, and never get back to where they were, which can be frustrating.
Next question is about bariatric surgery. What are the rates of weight gain post-op, weight regain, sorry, post-op?
I think it's around 10 to 25% will regain a lot of their weight. And so that's a real gap there, is how to pick that up and really to utilize drug therapy as well to help them. That's not something we had before. Um, uh, but on average, long-term weight loss is 25 to 30%. So that and reduction in mortality, morbidity, improved quality of life. And I just say that it pays society back within 3 to 5 years. So it's one of the most cost-effective treatments. And historically, our wait list was 10 years. Now there's a pilot program that if you connect with the Halifax Obesity Network and have dietitians you're working with that take them through the kind of binder, the wait list is more like a year or two. So just something to be aware of and reach out if you're keen. I do support people with that. And yeah.
Great. Any other questions? Anyone want to unmute and ask a question? I wasn't clear from your presentation, the oral form of semaglutide, is that actually approved in Canada yet for weight loss only or just for diabetes management?
It's not approved in the US or Canada yet. So that's the semaglutide 50 and Oasis trial. And so that's where it showed good weight loss even compared to semaglutide 2.4.
So would you
You
use
can't.
it?
Oh, go ahead.
I was going to say, would you still use it and like just sort of say I'm off label here?
And the 14 milligram is what we have available here for type 2 diabetes. And that's about a 0.75, equivalent to 0.5 of semaglutide sub-Q. So I have had people switch from, during that shortage, especially from semaglutide 1 to semaglutide 14 milligrams. And on average, they experience some weight regain, but they did okay. And you can't just double up on the oral semaglutide because of their kind of technology of how that pill is absorbed. There's competition between those two tablets. So unfortunately, you can't, or not unfortunately, we shouldn't do off-label, right?
Dr. Murray? You're muted.
Hi. I just wondered if you could comment on the value of private versus public funding for weight loss clinics. There are a number that are privately funded, quite expensive, and I just wondered if there's additional value to that, or whether that's a model that it has value to society.
I think it can, and I'd say my own, I've never felt comfortable going into the private space and willing to work. Our public system's a little slow, but that's going to be the most potent way to help the most people. And I think if people are going private, they really need to think about the package of what's being delivered and how good it is, how much the behavior support is, and the education. There's a lot of pop-up. It's going to be $100 billion business in terms of the pharmacotherapies. And in the past, with weight loss drugs that were hitting the market, these same kind of pop-up businesses are happening. And sometimes it's telemedicine and a quick 5-minute consult, and then you get the drug to your door. And that's not medicine. That's just profiteering. But a lot of some companies really do deliver very good care, and then it's just a difference in what is the client getting in terms of evidence-informed therapy. And I think it's tough to tell sometimes based on a website.
Aaron, you're muted.
So Dr. Bossé has left. She's off to another meeting. But I'm wondering, are there any other questions?
There is one more in the chat about, it's from RX, I'm not sure who that is, but regarding cost of semaglutide, et cetera, what sort of uptake can we expect on, one, existing, and two, novel medications, even with for folks with good coverage? Any sign of public coverage with Pharmacare hopefully on the horizon?
So Cadith reviewed semaglutide 2.4 a couple years ago, and at that point they didn't approve it didn't recommend approval. They noted the improved weight reduction, but at that time there was no conclusion about end organ complications, and they also had concerns about the cost, even though there was no negotiation with the company at that point about cost. So that's it for now. I think as you start showing, say, the SELECT trial with reduction in coronary artery disease, I suspect we're going to start getting disease-specific indications. But again, the CADIF and the powers that the negotiation between the provinces and whatever the Canadian system is to negotiate cost has to go through that to determine cost efficacy. I think it will happen, but it might just take a while. But we'll see. Maybe it will be better. The more drugs that come on the market, the more competitive it is, and the lower the prices. So that's going to be a good thing. And I've heard one patient yesterday said semaglutide 2.4 was covered by their Blue Cross, and I just said it's not on the market yet. So that's just a rumor. So I'm hoping the insurance plans are starting to already create their prior auth forms and things like that.
I don't see any more in the chat. Mike, do you? And I'm not seeing any hands up. One last opportunity to ask Dr. Mindrum questions before we close and thank him. Okay. Well,
I want to thank you all for love the work you all are doing. Hard work and so much. The scope of practice you all do is incredible, and I think hopefully getting a little more comfortable with obesity, like it can bring a lot of joy to the work, and patients are so appreciative, and I think for some people it was a part of their work they didn't enjoy necessarily, but just didn't kind of have the framework or tools to kind of get in there, discuss and care for. But it can be an incredibly joyful clinical experience working with people in this way, and hope that helps you all enjoy your work more and care for patients.
Lots of thank yous in the chat, Dr. Mindrum, and thank you once again for bringing this information to us. Have a good day, everybody.
Bye-bye.